All right, the next abstract is to be presented by Dr. Nator. If you could come back up to the podium, and representing co-investigators at Henry Ford Health System. There's been an alteration in the title of this talk. Revascularization of left subclavian artery may influence the incidence of spinal cord injury after endovascular repair of acute type B aortic dissection. Go ahead.
Good afternoon, ladies and gentlemen, again. As a small disclaimer, we had to rerun the analysis after we realized that there is a small subgroup of our patients that was accidentally excluded from our analysis, so we included them again, and we had to rerun the analysis again, which changed our title and, most importantly, our conclusions. So we have no other disclosures. So prophylactic left subclavian artery revascularization when intentional coverage is anticipated during TVAR is controversial. Some studies have shown no benefit to LSA revascularization after coverage. However, some other studies have shown worse outcomes, especially when looking at spinal cord ischemia and stroke in patients who did not undergo LSA revascularization before or after coverage. This table illustrates three of the many studies in the literature who looked at the impact of LSA revascularization after coverage. First one is a multi-center retrospective review published in 2013, which showed that revascularization of the LSA was not associated with decreased risk of spinal cord ischemia and stroke. The latest VQI study published in 2016 showed that revascularization of the LSA was associated with a decreased risk of spinal cord ischemia. A recent meta-analysis combining 31 observational studies concluded that revascularization of the LSA was associated with a decreased risk of spinal cord ischemia and stroke. Now, these three studies, in addition to most of the studies in the literature, were limited by their methodology, especially that they combined different aortic pathologies together without proper stratification. Some other studies had limited information on the aortic zones covered, and others combined different urgencies together without proper stratification. So our research question is as follows. In acute type B aortic dissection treated with TVAR and LSA coverage of zone 2, does prophylactic LSA revascularization decrease the incidence of spinal cord ischemia? To answer this question, we used the VQI registry and recruited it for all TVARs performed between 2014 and 2021. We included only patients undergoing TVAR for acute type B aortic dissection with coverage of the LSA. Association between LSA revascularization and spinal cord ischemia, stroke, 30-day and 1-year mortality was analyzed using univariate followed by multivariate analysis. So a total of around 19,000 patients underwent TVAR after excluding aortic aneurysms and trauma, conversions to open, and chronic cases of type B aortic dissection. We ended up with around 1,300 acute type B aortic dissections. Among these patients, 845 had their LSA covered and constituted our main cohort. Among the 845, 44% of the patients had their LSA revascularized prior or concomitant to TVAR. The mean age was 57 years. Most of the cohort were male and white. This graph illustrates the prophylactic LSA revascularization rates after coverage. As we can notice, there is an increased trend going from 42% in 2014 to 52% in 2021, and this trend was statistically significant. This table illustrates the distal landing zones. As we can notice, most of our patients had their distal landing zone to be zone 4, and patients who did not have their LSA revascularized were more likely to have more distal aortic coverage. This table compares the baseline characteristics between the two groups. As we can notice, patients who did not have their LSA revascularized tended to be younger and have a higher BMI. No significant difference was seen when comparing other medical histories, and patients who did not have their LSA revascularized were more likely to present urgently or emergently. When looking at intraoperative variables, patients who did not have their LSA revascularized were less likely to have a spinal drain placed preoperatively. Looking at univariate outcomes, patients who did not have their LSA revascularized had a higher incidence of spinal cord ischemia, stroke, 30-day mortality, and 1-year mortality, and all 4 outcomes were statistically significant. Looking at the multivariate analysis after accounting for confounders and starting with spinal cord ischemia, LSA revascularization had almost half the odds of developing spinal cord ischemia as compared to patients who did not have their LSA revascularized, and this was statistically significant. Patients who presented emergently and those who had prior history of PCI or CABG had significantly higher odds of developing spinal cord ischemia, and interestingly, prophylactic spinal drain was not associated with the development of spinal cord ischemia. Looking at stroke, patients who had their LSA revascularized had almost half the odds of developing stroke. However, this did not reach statistical significance on multivariate analysis. Patients who presented emergently and those with a prior history of cerebrovascular disease had a significantly higher odds of developing postoperative stroke. On multivariate analysis, LSA revascularization was not associated with 30-day mortality, and again, patients presented urgently or emergently had a significantly higher odds of dying at 30 days. Similarly, LSA revascularization was not associated with 1-year mortality on multivariate analysis, and patients who presented urgently or emergently and those with a prior history of PCI had a significantly higher odds of dying at 1 year. In summary, in patients treated with TBAD with LSA coverage for acute type B aortic dissection, LSA revascularization is becoming more prevalent throughout the years. LSA revascularization was associated with a decreased risk of postoperative spinal cord ischemia. Operative urgency was a predictor of postoperative spinal cord ischemia, stroke, 30-day, and 1-year mortality. To conclude, in patients undergoing TVAR with LSA coverage for acute type B aortic dissection, LSA revascularization may protect against spinal cord ischemia. This data may influence decisions as to whether LSA revascularization warrants the risk associated with it when treating acute type B aortic dissection with TVAR. Thank you, and happy to take any questions.
Thank you. Dr. Lee?
Thank you for your presentation. Just had a quick question. I was a bit confused.
Yeah.
You're saying revascularization after TVAR? That was one of your slides. So
yeah.
Why is it prophylactic? Why aren't you doing the revascularization before the TVAR and covering it? And if you're doing it after, what's the timing that you're looking at? Like how much after you cover the TVAR or the LSA, you're doing the revasc?
Yeah. So we actually did not include revascularization after this.
Oh, I see.
On the bottom left,
okay,
you can
these
see.
Are all, okay.
Yeah, prior to or concomitant. Yeah. Sorry.
Thank you. Go ahead.
C.W. Aker from Madison. Did you look at how much of the thoracic aorta you covered with your TVAR and in looking at not so much stroke rate, but paralysis rate? Did you have that as a factor?
Yeah. So this table illustrates the aortic landing zones 3, 4, and 5, and the difference between the two groups. And we did subgroup analysis. Let me show you 1 second. I knew someone's going to ask. This is a subgroup analysis for zone 5 coverage alone. Patients who only had zone 5, and there was no significant difference in all 4 outcomes on univariate analysis. Yeah.
And can you clarify, traumatic injuries were excluded from this, or were they included? Okay.
Yeah.
And then by distal coverage, you're including covered stent graft distal extent?
Yeah.
Okay. Thank you. Any other questions? No? All right. Thank you very much.
Anytime.